And just to let you all know too, if you have missed any of the previous webinars, everything has been recorded and it is all available on our website. So without further ado, I'm sure there's lots to talk about again in today's session. So I'm going to turn it over to Eric Rogers at BKD to get us started. Eric.
Thanks, Kate and Seneva. Appreciate the opportunity to talk again with the Delta hospitals today on our 4th of the 5th series in the COVID recovery. Today, as you can see from the topic, we're going to be focusing on recovery specifically as it relates to the revenue cycle. And I know that this is often a challenging, complex area for a lot of the first and second cohort hospitals that we've worked with in the Delta project. And for those that are on the call today from the third cohort beginning, who've been going through the FOA and some of the other community planning, the BKD team will be coming in a little bit later, working on some revenue cycle stuff. And but we wanted to go ahead and kind of tear into a few things today on the call and talk about what we've been seeing in some of the hospitals and give you some strategies, but then provide plenty of time for you today to ask some specific questions about what your organization can be doing to improve collections, registration accuracy, all those things that amount to that bottom line that you're looking for with the organization. We've got 3 folks on the line today that are going to be leading some of the discussion. We've got Brenda Chrisman, who's a managing director out of our Cincinnati office. Brenda leads our revenue cycle team. She's a nurse by background and training, and so her focus in the revenue cycle is really deep, particularly in that middle area. And then the 2 others that we've got presenting today are Sanjay Patel, and he's going to be talking about the cash acceleration piece and the AR management. And we've also got Deb Kozlowski. And Deb and Sanjay are both from our Chicago office and have been working with our second cohort of hospitals. Deb's going to cover some of the updates from the major payers, and she's also going to talk about some of that staff productivity and a remote workforce. So I'm going to go ahead and turn it over to Brenda to kind of get us kicked off at a high level, and we'll go from there. Brenda?
Yes, perfect. Thank you. And we can move to the next slide. We are certainly pleased to be able to spend some time with you today, and we think we do have some very relevant and actionable information that we're wanting to share, but I did want to just take a few minutes and maybe frame up that conversation because our goal is to be able to provide you information and suggestions, you know, as you navigate through all these changes and certainly the uncertainty that a lot of us are feeling that COVID-19 has brought on. So our goal, again, I think is just, let me just kind of frame it up with, start our conversation by looking at these slides here. And we can look at the graph on the left and say, hey, that really represents what that's looking at are the Medicare COVID cases that have been seen through June. And I think the key ingredient here is to realize that at this slide, the rural areas are not seeing nearly the same level of cases maybe as what we're seeing in the urban areas. But I'm thinking as we update this slide, if we were to bring that slide on forward into July or possibly into August, that we might start to see that shift happen, that the rural areas are starting to see some of these upticks in cases. And at least that's what we're seeing as we follow the various pieces of information that we can access on COVID cases. But look over at the right side of the slide, and that is, you can see that over half of all the Medicare COVID-related hospitalizations, they are currently logging in at a greater than 7 days, a length of stay greater than 7 days. So we think that hospitals need to be able to understand these trends and start to address any operational changes that you might think is necessary if you too start to see some of these upticks in the COVID cases. So with that, we can move ourselves. I think the first polling question might help frame up how you are currently faring with COVID cases. and let me get back there. And so the question is, has your hospital tested and treated COVID patients? Yes, greater than 50 patients, or between 10 and 49, or 1 to 9, or no, have not treated any COVID patients. We'll give everyone a minute to respond.
I'll give it 10 more seconds and then we'll close the poll for you.
Okay, thank you.
All right, here are the results.
Great. Okay. Wow. Okay. Over 42% of you have said you've treated greater than 50 patients. And then you can see the rest of those results. The next highest category is 10 to 49 patients, or 37. And 16% say no, they've not seen any. So very good. What I'd like to do now, I'm going to kick it on over to my colleague Sanjay and let him start us through the presentation. Thanks, guys.
Hi, everyone. Thank you, Brenda, for the great introduction. I'm excited to be here today and talk with you all about AR management, cash acceleration, and some self-pay strategies. If you go to the next slide. COVID-19 has negatively impacted many organizations' accounts receivable, so we'll discuss some action items organizations can take to mitigate this impact. COVID-19 has really made it difficult for healthcare organizations to manage their AR amongst many other priorities. COVID has affected not just organizations, but insurance companies as well, which complicates the payment and collection efforts from all parties. Many elective procedures have been rescheduled or delayed, which is decreasing charges. However, AR seems to be gradually increasing. Some other impacts COVID has include delayed payments, increased hold and follow-up times, and a large decrease in self-pay collections. It is important to note that it is important to prioritize self-pay AR in conjunction with insurance AR. One of the largest impacts COVID has on organizations is the increased backlog it has created since the onset of the pandemic. We have seen an increase in AR days and aged accounts for many, as well as an increase to charity care and bad debt transfers as self-pay collections decrease. Many factors play into this, such as unemployment and the insurance lag time. The goal for organizations should be to evaluate and understand the AR in order to focus on targeted areas that need extra attention in order to prioritize accounts and decrease the backlog. Leadership must understand the full effects of COVID and utilize data and reporting to understand where the current AR lies to make these informed decisions. Although this is a short-term strategy that I'll discuss in a few slides, some long-term goals would be to incentivize staff for resolving accounts, potentially hiring additional staff, mainly using system functionality to automate many of these workflows, and potentially using vendor support to work accounts. Go to the next slide. I wanted to use a real data example to illustrate a sample AR breakdown and how you can all use data to drive organizational decisions for short-term and long-term strategies. The table is a high-level aging by financial class of a sample organization. The data helps frame what priorities are needed to tackle the AR. Looking at the table, there are many trends and variances in the data. Overall, 3 major factors play into prioritizing the accounts that need to be worked: age, dollar, and timely filing. The first factor is prioritizing by age. This helps decrease aged accounts that are classified as at-risk accounts. For example, you can focus on a Blue Cross population in the balances from the 90 to 180 day bucket. Essentially, what you want to do is really start from the right and move your way back to the left to clean up all the older accounts. Another factor is prioritizing by dollar. This helps identify high reimbursable accounts, which can mean looking at accounts that are greater than $1,000 in balances, or looking at balances in higher reimbursable financial classes. Look at it from a return perspective. You can see that the commercial and Blue Cross have higher expected net revenue, and also a higher total AR, so it might be worth tackling those first. Lastly, prioritizing timely filing helps to identify accounts that will approach the deadline to file accounts and be non-collectible. This means understanding your timely filing deadlines and to know how many days you have until the accounts are hitting that deadline. You will want to consider both the initial and the appeal deadlines. Next slide. So as we talk about, AR management and what are some strategies you all can do to manage your AR and kind of work effectively to clean up some pockets of AR. One of the initiatives that we recommend for many of our clients is cash acceleration. So this is one of the initiatives that organizations can implement on their own to really focus on and hone in on the AR. Cash acceleration, is a top recommended strategy that digests the AR and focuses on at-risk accounts, as I previously mentioned. Kind of what, again, much to what I had shown on the previous slide, those priorities kind of come into place in this little pieces of the pie. So kind of starting from the right and kind of going down and then back up, there's some steps here to kind of do this initiative from a billing office perspective. The first step is developing work lists based on a defined set of criteria such as age, dollar, and timely filing. Then having leadership assign these work lists out either manually in Excel or automating through the patient accounting system. It is important to communicate expectations and goals with the staff. Then you want to evaluate the progress of team members through feedback and quality. Make sure the staff are asking questions and meeting ad hoc or through weekly huddles, and then they're accurately resolving accounts. Then you want to measure the progress through reporting and data to ensure payments are coming in and the AR is decreasing. And then lastly, what leadership will want to do is assess to reevaluate these focus efforts. You might want to reevaluate the workflows that you guys have currently been using or develop new priorities. The idea of Cash Excel is that this will take all outstanding AR and focus on very specific areas. This is a value around reassessing every 30 days or every month. As you see improvements, it's important to change focuses to tackle some of the AR that was lower on the priority list. Leadership should evaluate this initiative monthly to ensure success and goals are being met. Continuously thinking about how these methods can be automated in the system for long-term sustainability.
Yeah, and Sanjay, even just to add to this, and I really want to maybe call this out for everyone on the call today. This is something that Sanjay and I have gone into. I mean, I think I've done it with 50 or 60 organizations. And what this really allows is when you think of your AR in terms of a pie, we try to focus on one area at a time, understanding that due to staffing constraints, the remote work environment, everything that's been going on since the pandemic, you may not be able to touch the whole pie. The goal is to touch every account every 30 to 45 days. That may not be manageable in today's environment. So what this really allows is a focused effort to say, we know we can't look at everything, but what matters the most? Where can we drive that cash for the organization? And that's something that individually you'll have to determine. Sometimes it's based on those timely filing limits. If you have payers that are 60 or 90 days, you have to make sure you're getting to that timely. Otherwise, you can look at it from an aging balance perspective, or if you have the data, as Sanjay was saying on the previous slide, even the reimbursement. So for every dollar of effort, are you getting 30 cents back, 50 cents back, or 90 cents? And trying to prioritize that way. So you're really focusing on the accounts that are going to drive that revenue for your organization. Okay, great.
Yeah, absolutely. That's a good point Deb made, and it kind of dives into more of an elaboration on some of the data points. I think we focus a lot on insurance AR kind of naturally, and sometimes self-pay AR kind of gets lower prioritized. So, as I mentioned on an earlier slide, it's really important to prioritize self-pay AR, right? And knowing the effects of COVID has on insurance AR, sometimes it will have a huge effect on self-pay AR. And I'm not sure if you all caught, the previous slide with the data, but sometimes, the self-pay AR in the previous slide can be about half of the AR. So it is also a big part of the organization's financials. You want to factor in self-pay AR, obviously, again, right now, because COVID has left, millions of Americans unemployed, without jobs, changing coverages, and things like that. It's important to have strong policies in place to get the most collection, out of self-pay patients. This could be a wide variety of your financial assistance programs, discount policies, how you all set up payment plans, how you guys collect payments both in pre-service and post-service, and really just, we want to break down the total AR and understand where your AR lies to help kind of roll out some targeted efforts. You can see here that we're looking into self-pay AR and specifically into some of the true self-pay versus some self-pay after insurance patients. Implementing some of these strategies will also have a high reward benefits for the hospital. Financial assistance, will become a larger player in healthcare organizations. As I mentioned, COVID has left millions of people without jobs, more dependent on financial aid, and things of that nature. Understanding and upstreaming the potential coverage screening options during registration is important. This includes understanding, your Medicaid guidelines for your state, the eligibility process for your patients, as well as other options such as workers' comp, COBRA, and disability. Also implementing a robust charity care program and write-off policy will ensure that the organization can meet the needs of the patient without having to write off any avoidable accounts on the back end, and also decrease self-pay AR and transfers over to bad debt. On the flip side, for patient responsibility after the primary insurance phase, you should define a clear set of criteria for payment plans that patients understand, as well as implement partial payments or promissory notices prior to service so patients can pay over time and reduce bad debt. This also includes requesting co-payments and deductibles prior to service and using strong scripting and to ensure collection efforts are all being met. I think next slide. And so really, what we mean by some of the self-pay strategies, as we mentioned on the last page, these all fall into kind of a classification of, the three biggest factors or barriers that really kind of build up, a baseline patient collections program. So as we all know, there are many barriers and constraints to patient collections. Patient collections really involve a balance of multiple barriers, constraints, all equally: patient's ability to pay, their satisfaction score, and the actual responsibility to pay. We know your organizations are juggling all three of these, but we want to, make it clear that none of these will take priority over the other. We understand that some of your communities may be struggling in self-pay collections, so there must be a balance between, again, the ability to pay, the scoring of the hospital, and most importantly, patients being aware that they do have a responsibility to pay. So as I mentioned before, COVID has, left millions of people unemployed. It has decreased commercial insurance coverage. It has an ongoing effect on the national coverage mix. Hospitals must use strong financial assistance programs, especially during registration, to work with patients to collect payments or possibly reschedule service. Ensure that these financial assistance programs are performed during scheduling or registration, and really just wanted to point out that it's important to kind of implement these through the registration and pre-service. So again, as I mentioned before, the promissory notices or partial payments, they are collected prior to the service instead of after reaching out to the patient to collect payment. One complaint that I commonly see across a lot of our clients and different organizations is that, patients are unaware of balances prior to service, and they're unaware of what they owe. It's important to really ensure that patients have been authorized for service and that they're notified of their estimated liabilities prior to service so that the patient can make an informed decision on proceeding or declining service. And then lastly, piggyback a little bit off of the satisfaction score bucket for the patient responsibility to pay, not only is it important to communicate responsibilities to the patient, but it's important to implement strict policies to work with the patient for partial payments and payment plans to collect balances that the patients owe prior to service. Organizations must decrease a lot of the discounted services that they continue to offer, but at the same time tackle this through targeted scripting and training. Again, we know that this is a balance between these three buckets per se, but ensure policies are being followed for each of them to ensure that you all receive the most return on your patient collection.
Yeah,
Hey,
and
Sanjay?
one thing, oh, go ahead, Eric.
Yeah, we had a hospital recently from COVID, similar to kind of like tax time when people get their tax returns, that they looked out across their self-pay balances. And some of it was true self-pay, but another bigger component was balance after insurance that had just began to accumulate. And what the hospital had done is kind of out of COVID is offered a pretty steep discount. They were offering, I think it was either 40%. So if I'm a patient at your organization and over the last year I've accumulated balances from my doctor's office visits and maybe a couple ED visits, and I had a balance of $2,000, they were doing a one-time payment for, with a 40% reduction if I would pay off balance. And they were calling patients. And so they ran a list of all the patients who had the high self-pay balances remaining, and were using their staff that were kind of slow at the time to make calls and say, hey, we've got a 40% discount right now that we're allowing patients to take advantage of. If you can pay off your balance, we'll write off 40% of it. And they kind of took a pretty proactive measure in managing that, and were pretty successful in the first few weeks of getting some patients to pull the trigger on that. I didn't know if there's anybody else that's employed a few strategies similar to that here with COVID, and if so, what's working? So I'll hand it back to you, Sanjay, and Deb, sounds like you had a question, but if folks want to put in some of their ideas that they've put into action here over the last few months, feel free to put that into the chat box or speak up.
Yeah, Eric, and I think that's a good point. And Debbie, I'll let you jump in here in a minute. I know you had a point to make. Eric, I have seen a lot of strategies like that, and the example that you provided is a good example of kind of the benefit for the hospital, right? So I've worked with a lot of organizations that are capturing or calling patients with balances from 2-3 years ago, and I think there's just it's a higher reward for the organization instead of transferring those over to a collections agency or writing them off. These are the types of initiatives and strategies where organizations can do kind of internally to roll out this discount program. As you mentioned, can be a temporary thing. It could be a long-term-ish thing, especially with COVID. It's not a bad option to start kind of making patients aware that hospitals and organizations are willing to work with them just to receive payment, and making the patients aware that they still have a responsibility on their end to pay.
Yeah, and Sanjay, I think you summarized it perfect. And Eric, you're spot on. I mean, those are really great opportunities, and trying to make sure you're offering support for patients during this time. And I think offering kind of those one-time discounts are a huge benefit. As Sanjay said, something as steep as 40%, we probably recommend starting with some of the older accounts because you don't want to discount some of your new accounts for patients that are willing and have the ability to pay. So making sure you're focusing what are the accounts and then what is the opportunity. And we've seen organizations offer prompt pay discounts of 10-15% so that when registration sees that patient again, they could see, oh, I have an outstanding balance for a prior account. If you pay it in full today, I can offer you 15% off. And we've seen a lot of success with those types of initiatives. So that's a really great idea. One of the other items I did want to bring up, and we didn't touch into it during this presentation, but I'll go ahead and share a link for everyone in the chat. But another item to consider with self-pay and seeing the first CPE question for organizations that had 50+ positive COVID patients. If you are aware, have enrolled, great, but those that haven't, there is an uninsured coverage option in the last CARES Act. And what that allows is if you are testing or treating self-pay patients for COVID, you can get reimbursed Medicare rates primarily for those services. If you've even had one patient with a large balance, it would be worth the investment to enroll in the program. It is very simple to set up. And then all it is instead of billing to the patient balance, you would actually bill it like you would an insurance company. And there's some rules and criteria that the clearinghouse has already set up to allow for that. So I'm going to go ahead and share that link now if your organization has not already taken advantage of that opportunity. That would be something to look into further. And, you know, I'd be happy to help answer any questions that come up as well. Okay. With that, we can probably move on to the next slide.
So great. Thank you for that link, Deb. And you know, before we kind of transfer over to the second question and the next topic, you know, as Eric mentioned, you know, some of the strategies or plans or action items that you all have been doing at your organizations, if you guys don't mind writing them out in the chat box, I'll have that open on my screen, and then we can talk about it, you know, after the next section. But on to our second polling question, you know, as we discuss self-pay AR and how some of the impacts it has on your organizations, really, does your organization notify patients prior to services of their responsibility? Yes, you know, organizations, you know, utilize a patient estimator tool. Yes, do you guys use a payer portal or a website? Do you sometimes, depending on services and availability, or do you guys you guys don't, or you guys are not sure? It is multiple choice, so you can select more than one, and then we'll just give it, you know, 45 seconds or a minute or so.
I'll give you guys 20 more seconds.
Okay, great. So it looks like the majority of you all said sometimes you guys notify patients prior to services, you know, depending on services and availability. And, you know, I think this is the major common theme that, you know, we all get from different organizations. You know, best practice, it would be great to invest in utilizing a patient estimator tool. You know, a lot of vendors do support this, do provide this, and the patient estimation tool really, it helps you all obtain real-time and accurate results, and you know, it spits out cleanly, kind of just on the EHR with deductibles that are owed, what the patient's co-payment is, what the co-insurance might be, what types of balances they could apply for, any historical balances. So you know, I think there would be a big push here, especially after COVID, with just ensuring these payments are coming in. The best way to you know, do any kind of reconciliation, ensuring all payments are coming in, the best starting spot would be utilizing a patient estimator tool, payer portals and websites, things like that. But yeah, sometimes, you know, just depending on the services availability, you know, we understand that a lot of your organizations have a lot of walk-in patients, and so that's also another factor that will play into this as well. Great. Can move it on, and I will turn it over to Deb for payer updates.
Great, thanks, Sanjay. Moving into payer updates, and we can continue on to the next slide. We really wanted to provide an overview of some of those critical changes that have occurred during COVID that will impact you all as providers. The focus for this is going to be on a couple of these areas particularly, and that's the reduction in the authorization requirements and the expansion of telehealth services. And we're going to particularly go through the top 5 commercial payers: Aetna, Blue Cross, Cigna, Humana, and United. We can continue along to the next slide, and we're going to start with authorizations. Oftentimes, these are really a consuming time area for providers to get the authorizations, ensure that everything has been approved as stated before patients can be admitted, transferred, or services can be provided. This is also where we see a lot of what we define as preventable denials. So a couple of the biggest changes we've seen during COVID that we wanted to address is Aetna reducing the 3-day minimum prior hospitalization requirement before going to a post-acute care facility. Blue Cross has waived some prior authorization for diagnostic tests and medically necessary services if it is COVID related. Cigna has also waived some prior authorization for admissions to post-acute care facilities, and they've expanded some of their timelines from 3 to 6 months. Humana has waived some prior authorization requirements if it's a COVID diagnosis, but they still do require some acute care discharge summary planning submission. And finally, United Health has also waived prior authorization admissions for post-acute care. These are just a few of the authorization-related changes that these payers have taken on during this time. So it's really important that you go to the payer websites and read through what it's been today. A lot of these were stated through June and have since been extended, but it's state by state at this point. As we all know, with the pandemic, some states are faring well than others. We'll continue along to the next slide and get into telehealth. So this is some huge opportunities for rural health communities for a couple of different fronts. What we first wanted to start with is you guys providing services to your patients in your community. With some of these expansions, they've eased restrictions from what the government is allowing for telehealth providers. Commercial payers have also caught up, and what they've done is for Aetna, for instance, they've waived copays for telehealth services. That way they're easing the burden on the patients and almost encouraging them to use telehealth services when they're available. Blue Cross has also expanded access to telehealth services. Cigna is reimbursing providers for virtual care at the same rate that they would for their standard face-to-face visit if it is related to COVID. While Humana and United have allowed for telehealth visits, even if you do not have a video functionality, they will still reimburse it for audio/telephone only. So that's huge for a lot of the regional hospitals who may not have the technology in place to set up video links for their appointments. This will allow that phone call, that touch base, without having to have the patients come into the clinic or the hospital for the services and risk exposure. The flip side to this is as well, now that telehealth services have expanded and a lot of companies have really started rolling out enhanced telehealth features, you can start getting specialists to remote into your facilities for your patients that previously were unavailable. There are still state-by-state limits, and often providers cannot cross state lines. But if you have, let's say, needed a specific specialist that your patients have driven to a larger health system in the state to receive services from, I'd work with them to understand, can you start offering that? How do you start partnering with them at your sites to work together during this time? And I think, as we all have figured out by now, this pandemic is probably going to last for a while. So making sure that you're taking the time and the work now to figure out, how do we set this up for a long-term plan? Moving into the next slide, we'll summarize all of this with just helping to understand that commercial plans have made a lot of changes during this pandemic to help providers trying to provide services during this time. So importantly, if you do start receiving denials or having issues with getting claims paid, we would highly recommend you go to your payer websites and start working through some of these links that they've shared and some of the restrictions that they've allowed. One thing that has not changed is the timely limit to appeal for denials. As Sanjay mentioned earlier as well, Medicare, for example, allows a year to submit the initial claim, but if you do get a denial, you only have 120 days to appeal. Those have not changed. So making sure you understand you are appealing, and every appeal resets that timeline. I have seen, and I know specifically we have some on the call from Mississippi, that certain payers such as, I think it was Blue Cross, one of the plans tried limiting appeals to one. That has since been shot down. You could work with them. You should not have any restrictions that way. So if you start experiencing any issues, please feel free to let us know. We'd be happy to work through that. There's also some additional guidance that we've provided. A couple of more information that we have is around COVID testing requirements and procedures and what payers have done to, again, ease the burden on the patients. No copay requirements for testing, a lack of authorizations needed, and also expansion to some pharmacy regulations, including early prescription refills. And we've included some links to that thoughtware that our colleagues have wrote regarding that. And that's actually really good because it gives you direct links to the 5 major payers and where we got this information from.
Deb, I think that brings I think that brings up just one point, and that is to say, as Deb mentioned, we can link you back to the 5 major payers, but I think probably what comes out loud and clear is that it is a continual process of trying to stay up to date on what that information is. So we would recommend that you continue to check those websites, maybe even make contact with some of your payer reps, especially if you start to see some things that you that does not make sense on the denial side, that it would be important, because I think it's ever changing. And I think just as everyone on the provider side is trying to get comfortable with how to navigate under these new rules, I think the payers are also having some of those same hiccups, and we see them being, claims being processed differently. So it's just a matter of saying, hey, you just got to recognize, you got to pay attention to how those claims are getting paid.
Mm-hmm. No, great point, Brenda. And also too, the last resort, I mean, pick up your phone and call your payer reps and start figuring out what rules and criteria, talking through with them what is allowed, what isn't. And just don't accept the initial denial or the initial response and not do anything with it, because you have more opportunity during this time to work with them to get those services paid.
Deb, I know that whenever you do the revenue cycle assessments for the hospital and the clinics with the Delta hospitals, one of the things that you'll help them set up, if they don't have it already, is a denials committee that meets on a pretty regular basis. And so, just want to encourage folks to be thinking about that. If you don't have it already, to form a denials committee there at the hospital, to be able to keep very close tabs on things by ANSI codes for the reason that things have denied, but also payer specific, to try to be as quick as possible to see when these things are coming up in the system, get to the root cause, and work with your front office folks or your business office to make some correction from a denials committee standpoint.
Yeah, thank you for bringing that up, Eric. And just to expand on that as well, when we say a denials committee, we include registration, HIM, patient financial services, your billers, your follow-up reps, everyone getting into a room and really getting down to the root cause of what occurred, and going through claims individually. And so making sure you're staying up to date on what those denials are, you're aware of the patterns and what you're seeing at your organization. Thank you.
I just wanted to bring up too, one of our sites had noted that, said we're finding Blue Cross Blue Shield deny telehealth visits. On the hospital side, via our cancer care clinic, they won't pay the separate facility component of the telehealth charge like other payers will. Furthermore, they have denied rural health clinic telehealth visit claims, and these services were provided in May and June under CPT codes 99. You guys seen that as issues elsewhere?
Yeah, as we'd mentioned, that it is so common that it becomes each of the payers seem to be applying the rules differently. Yes, we can go back, and we certainly can on that situation go back to some of the finite pieces of that and say, hey, based on the guidance, this is not what we would expect. But that's what we're talking about, is to say, hey, we have got to get to the point of being able to identify, not, I don't want to say real time, but very expeditiously being able to find where these denials are occurring and pocket them, just as these folks have done. They pocket them into a location and a payer, and our recommendation is you go back, you lay out your facts and go right back to them and make sure that we're talking the same thing, you know, that we can explain, no, you know, this is what we did, you know, because I know the devil's always in the detail. And so for us to try to answer that question on the fly would be hard. But what we would typically do is take the detail that you know, what services were provided and look at the remits, because we know there's oftentimes it's a nuance. It's a, oh, you didn't put this modifier on, oh, but you combine these two codes and you should only put one. So certainly understand that, but to say for, you know, those specifics, don't have an answer off the top, but to say that it is not uncommon that we're seeing this as an issue, and it takes a lot of time and energy for individuals to go back and get these things corrected.
Sure. Thank you, Brenda.
Carrot Joe did respond back. She personally messaged me that we are going to claim those denials as COVID expenses under our stimulus fund utilization. Is that even appropriate?
In the sense that that's almost like, I don't want to call it lost revenue, but there's a couple ideas behind there to say, you know, they're going to be tracking all the expenditures that they've had that are COVID related. And this would be, I think it might be premature to say whether or not that would stick as a allowable fund, but that's our recommendation, is any category of expenses that you're currently can relate back to the pandemic, that you keep track of those. But I think I understand what she's saying, is that they're actually going to take those against some of their federal funds that they've received to be able to support that they should maintain those funds.
Yeah, and especially too, from I guess my perspective and working with clients on a lot of these denials that have come through, specifically that are COVID diagnosis related. Payers are struggling to get their systems updated timely, and so we are not surprised that you're getting telehealth denials for some of these services. We have seen that across the board, and it is very different reasons. So we'd be happy to talk further to help you understand more of what occurred and what we can recommend to kind of get some next steps around it. I would recommend working with the payer to try to get those paid before defaulting to that expense fund. Because you are going to have other salaries and expenses that will probably satisfy that. So unless you're struggling and that's why you're trying to put that there, that I think, as Brenda said, that might be a stretch, since it was a denial from a payer that you may be able to still work through. So we can talk further offline about that. Okay, moving into our last section, remote staff productivity. We'll get started with a CPE question. We would just like to understand, what is your current revenue cycles work environment? Are you still all remote? Are you mixed remote and in an office or your hospital? Are you back to the office or hospital? Or are you not sure? We'll give everyone a few minutes to answer that.
I'll give you guys another 30 seconds.
Glad to see that. So we got a little bit of mixed remote in the office, and otherwise you're back in the office or the hospital. So I'm glad that you guys are moving out of the remote work environment. So we can continue on, and we'll make sure to talk through some of these strategies. Managing from a distance, or in this case, in a mixed remote in-house environment, or back in-house post-pandemic, during the pandemic, I should say. We wanted to provide some clear guidance and suggestions for how to manage during this time and how to set expectations as you're coming back and there may be backlog and priorities, and how do you work with your teams regarding that. The first item we'd recommend is communicate. clearly and consistently. And a couple of ways that we've had success doing this is through daily huddles between team members and their managers. This could be a simple 10 to 15 minute stand up with your business office. Same with registrars or any other area. Using that time to touch base on anything that happened the day before, what to expect for the current day, and answer any questions that come up from the team. We would then also recommend having weekly touch bases. These will be one-on-ones with managers and their team members. And this really allows more of that transparency that individuals who may not speak up in the group as often would feel comfortable having during that one-on-one time. And again, it could be as simple as a 15 to 20 minute touch base. It does not have to take a ton of time. And then from a leadership perspective, the C-suite, we'd recommend quarterly town halls. So if you've not already been providing I know our company particularly sends out a weekly email with a 10-minute video from our CFO. And he goes into kind of what's going on, what to expect. Moving into this world, we would recommend even just quarterly or monthly. And that's usually either an email, you can have a Zoom meeting, a stand-up, whatever works for your organization. But having that touch base from leadership really shows top down the directive and how the organization is doing. Next, while having these communication meetings, huddles, it's very important that you acknowledge fears. We are all in a difficult time during this pandemic, and I think it is very important that you acknowledge what the employees are worried about. You don't always need to have a solution, and I think that's what's often hard for leaders to communicate. A prime example is, coming back, we do have a lot of self-pay. We're going to have to start pushing harder to get some point of service collections for co-payments. Maybe that was never done before, so this is going to be brand new for your registration staff and for your schedulers. So making sure you call out, we know this is new, we know this is a lot, here's why we need your support. There has been a lot of an increase to the self-pay balances, and it's extremely important we get that payment timely. It's going to save us costs from billing, calling, sending it to our vendors on the back end, and that's really why this is valuable. We'll work with you guys on training and scripting. Please tell us if you have questions or concerns, but we'll get there together. Something as simple as that. Make a plan, and most importantly, follow through. And this is what gets very hard is, I'll go back to the point of service collections. Letting people know, we'll try collecting on co-pays is not as specific as you're expected to collect on copay for every single commercial plan and every Medicare. We know Medicaid we won't need to. So how do we start enforcing that? How do we start getting deposits towards deductibles? So making sure you establish simple, clear, concise goals. And in most of your cases, we're out of the remote working environment, but understanding for each of your areas as well. I mean, even for follow-up, the expectation may have been pre-COVID that they work 50 accounts a day. Is that still an expectation today, or should we lower it to 45 or 40? What is that going to look like for your organization? So making sure you have a plan, you communicate that, and you hold your employees accountable is really going to be critical for implementing a lot of these changes. You also want to be flexible. So as I'm saying, you develop a plan, you hold people accountable. We also understand that we don't have all the answers or solutions, and often we implement ideas, goals that ultimately have technology limitations. Your community just laid off 100 people from the main employer in town. Now all of a sudden you have to reset your expectations. So being open for feedback. As you implement this, it's not like we're saying, okay, you set a goal, everyone complains, a week later you lower it. We're saying to be strategic. So after you set a goal, you determine with the team, you hear what's going on, then you determine if you want to reevaluate and readjust. And does that still fit into the needs of the organization overall? And finally, as always, celebrate success, big and small. Any reward for individuals or teams is going to continue to encourage momentum from the rest. We would recommend doing things such as even incentivizing the team. Going back to the point of service collection, if you as a team hit a certain dollar amount this month, we'll give everybody a pizza party. Something like that really boosts morale on top of incentivizing them to start working towards a goal as a team, as opposed to trying to individually, or, you know, the one person who may not be on board with the change is now going to be influenced by those on the team that want that incentive and they want to do well at that goal. We can continue on to the next slide, and I see we're coming up to our time, so I might cut these last couple short just a little bit. But as we talked about goals, I wanted to really get into making sure we understand the incentive or the goal is to set SMART goals. And SMART stands for specific, measurable, attainable, relevant, and time-based. A prime example is we expect you to collect co-payments on 50% of the patients you register every month. It's clear, it's specific, there's a time, attainable, hitting 50%, not 100, things like that. One thing that you really want to determine for your organization when you're setting goals is determining where were you pre-COVID? Did you have goals for each role? How do you create those goals? Do those goals continue to work today, or should they be adjusted in the new environment we're in now that COVID is here? Also understanding, are your goals multidimensional? One way that we do this as an organization is when we go in somewhere and we help people, let's say, working through point of service collections. We expect you to collect 50% of all co-payments or $500. So setting multi-dimensional goals like that really allow them to feel like, okay, if I don't have enough opportunity or if I have a lot of volume, you can kind of hit it on either way, and it doesn't feel as pressured for the employees trying to achieve that goal. Most importantly, can you measure the progress? This is going to be critical because anytime you implement a goal, you have to be able to hold the team accountable. And I know with a lot of the regional hospitals, we struggle from a technology standpoint to have that productivity reporting that Epic offers, the data analysis that some of these bolt-ons can do. And so what we're trying to do, and we'll get into this with the next slide, is show you ways that you can still do this even without having some of those technology or productivity metrics. Finally, we really want to understand what management's major concerns are and how can the goals address them. What we mean by this is, what should the organization focus on? Are we going to prioritize point of service collections and working denials? Do we have teams established that maybe perhaps we can create a financial counselor to support more of the self-pay efforts pre-registration to take that burden off of registration? How do you work within your organizational structure and constraints to achieve the organization's goals? And moving into the next slide, we wanted to provide a sample of what we've done at a lot of organizations. And so this is a quality assurance report. And in this case, it's for follow-up. Usually for these types of projects, what we would recommend is if you don't have a way to manage productivity for your team individually, then at the end of every month, something as simple as, in the example of follow-up, all the claims that have been billed that we still have an outstanding balance regarding. Can you see notes for what the team did? Great. Running the notes that have been entered, running the touches from your team, and then what we would recommend is even just taking 5 of them a month and just reviewing each one individually. This spreadsheet usually takes us 15 minutes. So you can do it for each individual. Let's say you have 5 people on your team. You can plan about an hour, hour and 15 minutes of your day and get through all 5 one time a month. And what we do is, by trying to find those accounts, is you really want to ask certain questions. Was the appropriate account status identified? So was there a no response that you needed to call the payer or check the payer website on? Did you get a denial that needed to be investigated? Was it something that was coding or eligibility related that needed to have a call to another department? Then you want to evaluate, was the appropriate action taken? You have a no response, someone notes, Blue Cross takes a while to pay, we'll follow up later. That's not an appropriate action. You should check the website, make sure it's been received, And if you didn't do that, then what you see is as you go to the right under account number 2, you get a 0, so you don't get points for that. As you continue through the questions, you'll see then we put a weight on the accounts noted. Was the note documented correctly and clearly? And again, we want to make sure the note is professional, clear, concise, and anyone can pop into that account at any point and know exactly where the previous person left off. And ultimately, too, was the account resolution appropriate? Did they take the right action? Did they note it? Did everything flow through as expected? And what you can see based on the score below is it's simply saying, yes, you hit all the buckets that we would have expected, great job, or no, this was an account you didn't do correctly and we need to improve. That's where managers can really then meet with the teams one-on-one to say, here were the mistakes, here's what we would have done different. Now you can train and educate so that you don't continue to have those mistakes for those team members. And with that, I know we have about 3 minutes left, so we'll go into wrapping this up if there's any questions.
And I like Bethany's comment. She was noting on the SMART goals that she often likes to replace the word attainable with aspiring. So
I like that, yeah.
Yep.
We don't have any questions coming in. I don't see any yet, but I do want to put another plug. Just remember that you can get ACHE credit for these webinars, for all of them. And so please contact Seneva Heckman if you would like to receive ACHE credit. This is number 4 in the series of 5. So next Friday, August 14th, will be the final one in this series. And that is on physicians and strategic planning as we're moving forward. So I want to thank everybody today. Thank you, Brenda and Sanjay and Deb for coming and presenting, and Eric for joining us too. And everybody have a really great weekend, and we'll be back together next Friday.
Thank you.
Thank you.
Thanks.